Hi, everyone. I'm Andrea Fava. I'm a physician scientist from Johns Hopkins, connecting here from Eular in beautiful Vienna. And I wanted to give my thoughts about tapering of immunosuppression in lupus. There's been a lot of research going on in the last few years, new clinical trials, always trying to use less treatment or at least less steroids. And this year, this has been reflected in many sessions. In particular, there was one focused on how to taper or withdraw treatment in rheumatic diseases. And I wanted to focus on the talks that focused on lupus. The first one was from Murray Horowitz from Canada, and they wanted to tackle the idea on how to taper that last 5 milligrams of prednisone in patients with lupus who are in remission. And they started from a previous experience from a Toronto cohort, the Cortical Loop trial, in which patients who were on remission but were still on 5-prednisone basically had the prednisone withdrawn, and the experience was not good because after 1 year, 27% of the patient had a flare as compared to 7% of the patient who remained on prednisone. And so they took a different approach and they elaborated this taper regimen by which patients had to taper prednisone by on average 1 milligram every 7 weeks. And they had more than 100 patients per group. They were randomized and propensity matched. And it was quite interesting to see the results because the surprise was that the patient at 1 year who flared more were the patients who remained on prednisone 5. And so they were like 29% of flares in the patient who remained on prednisone versus 17. And at 24 months, it was pretty much the same with just a higher number. What was interesting to see is that the damage accrual, as expected, was much higher in the group that remained on prednisone with a 17% of total damage accrual versus 6.9 patients that increased their damage. And the damage accrual was both from prednisone and also non-steroid independent. The reason for this higher flare, it's unclear, but it's definitely an interesting one. The second session I wanted to comment on is about the tapering of immunosuppression in patients with lupus nephritis. And this was presented by Dr. Panagotopoulos. And they enrolled 137 patients that were induced for lupus nephritis, and they were mostly on mycophenolate maintenance. And after a median of about 3 years, they decided to taper, actually withdraw mycophenolate, and they looked over time at people who flared and looked for predictors of flares. And what they found is that being non-responders in terms of lupus nephritis at 1 year was associated with a higher risk of flares, and instead having an early response was protective for not having a flare upon removal of mycophenolate. Having higher prednisone use at 12 months was associated with more flares, whereas being on hydroxychloroquine was protective by cutting in half the risk of having flares. Having class 5 lupus nephritis had less risk of flares, but I think that the striking finding here is that, sure, we want to taper immunosuppression. We want to sometimes take this little risk, but this risk comes at a price. Because in fact, the patients who flared had a significant increase in the risk of losing GFR permanently, with a GFR drop of more than 30%, all the way to end-stage kidney disease and death. With a rate that was quite high. So there were 53% of patients who had one of these adverse outcomes among those who flared, who taper mycophenolate versus 16. So quite high. So we really need to find a strategy on how to best decide who are the patients in whom we could safely taper immunosuppression and not just hanging it because it comes at the risk, a permanent risk for patients. And of course, there are studies that have been described in this meeting, such as the ReBioLoop studies led by Ioannis Parodis and Fred Usiel, in which they are looking at the value of per protocol repeat biopsies after 1 year of treatment to decide eventually how understand how we could use this information to taper. And of course, there are big proponents of doing repeat biopsies to do so. And of course, I'm biased, but I think that the answer will come from non-invasive biomarkers, which will help us eventually to decide who we can taper. And the very last comment I want to make is, again, on prednisone use, not so much about tapering, but it's a comment. It was a study was highlighted in the plenary on the first day by Lauren Arnault, and there was a plenary on what's on the horizon for lupus, and he highlighted a study from Ali Duarte's group at Mayo, in which they did a meta-regression on several lupus nephritis studies and looked at the effect of IV steroid pulses on the rate of response in lupus nephritis. And what they found that patients who received IV pulses had higher rates of response without significantly increased toxicity. So this is giving us a sense that perhaps hitting hard at the beginning, it's a better strategy that will allow us to use less prednisone later on and therefore avoiding damage, which resonates on the approach that we often have in some of these bad flares. Anyway, very interesting studies, very interesting comments heard here at Eular. And for more information, you can go on Room Now on the website. Thank you.